Good evening. Am I audible, Devaprasad?
Yes, yes. Just to add one line, Professor Dipanjan Bandyopadhya is the past president of our organization, and he has been very much instrumental and supportive for our state chapter's growth. Over to Dr. Bandyopadhya, please. Please go ahead.
Good evening, respected chairpersons and seniors and friends from Tripura. It is really very encouraging and lovely to see all of you once again at the hopefully at the fag end of the COVID epidemic. I hope my slides are visible. Shashwata, do we have our slides? My topic this evening.
Sir, my share is disabled. I am requesting the host kindly access me the share, please.
Yes, Shambhumitra, can you have Dr. Shashwata allow him to share my slides?
Yes.
Shambhumitra. Yeah, I think we can see the slides and we can put them on. My topic this evening is pretty difficult because we will be talking about PUO. And as we all know, that PUO is a headache for the clinicians. The next slide. This is basically a group of illnesses in which the cause of fever remains undiagnosed, or the etiology remains unestablished despite basic fundamental investigations. And although medical science has progressed, just how we were hearing, from clinical ankylosing spondylosis to biomarkers and radiological spondyloarthropathy to the era of biologics, the condition remains as difficult for physicians as it was when it was described. The next slide. These were two gentlemen who gave us the concept of PUO. So it had a temperature dimension on several locations, not on a single location. Number two, this illness had to be more than 3 months duration. The definition was modified later, 3 weeks duration, the modified later into 2 weeks, and no diagnosis after 1 week of inpatient investigation. So these were the criteria at the time of when PUO first became an established entity in the around in the 1960s. Why the criteria? Number one, the cutoff temperature was mentioned so as to accommodate a variable natural temperature variability in several persons. Why the duration of more than 3 weeks or 2 weeks? Because there would be several acute infection or infective causes that will either settle down itself or make it clinically manifest for the diagnosis to become obvious. And lastly, why 1 week of inpatient investigation? This was to allow sufficient time for a reasonable performance of the baseline investigations. The next slide. We have long and longer lists of diseases or entities that can present as pyrexia of unknown origin. And they can be bacterial, they can be viral, they can be parasitic, and more fungal infections are becoming prominent as causes of PUO. We all know, we talk of culture negative infective endocarditis, and then we talk of the infections like your brucellosis, rickettsial infections, non-tuberculous mycobacteria. So these are the infections which can present as pyrexia of unknown origin, which are difficult to diagnose either from a clinical standpoint or from the investigational standpoint. The next slide. More importantly, other than infections, we can actually have inflammatory and neoplastic conditions which can manifest as pyrexia of unknown origin. We were just now talking of spondyloarthropathy, but then probably the two most common entities are giant cell arteritis and Still's disease. SLE, as we know, can present as prolonged fever with non-specific symptoms which might go unrecognized or undiagnosed either way, and several solid tumors can present as PUO. I remember when we were house staffs in the Department of Cardiology, we were told that one of the most common presentations of atrial myxoma was pyrexia of unknown origin. So you have all these inflammatory cytokines which are being liberated from the atrial myxomas or myxomata, and they used to present as PUO till the time echocardiography was performed and maybe the myxoma was picked up. One of the common causes of PUO that we see in our clinical practice in the neoplastic horizon is hepatocellular carcinoma. Apart from this, liver mets can present as PUO. I will not exactly go into the miscellaneous causes because possibly everything under the sun can at some point of time present as pyrexia. But as clinicians, we must remember an entity called drug-induced fever. And there are several drugs which can cause fever, either at the onset of their use or sometimes during the course of their consumption. The next slide. We also know that when we talk of the etiology or diagnosis of PUO, we must remember the clinical probability, meaning the ethos of IACM, the scenario, the setting, the age, gender, risk factors, ethnicity, occupation, exposures, all must come into the horizon when we deal with the probability of an etiology as the diagnosis of PUO. The next slide. So basically, a conglomeration of historical events, clinical examination, and judicious use of investigations are required. It is very often that you and me tend to lose track of our priorities or our protocols, because when fever doesn't subside and the patient and the relatives are jittery, the clinician becomes more jittery, and possibly we lose sight of the sequence of events that we should be following. So basically, let us remember a very thorough history taking, clinical examination which is meticulous, issues like lymphadenopathy, scalp tenderness, cardiac murmurs, which we often miss or often forget to perform, and above all, a proper blood count with a comment on the peripheral smear. Apart from this, of course, we have cultures, we have inflammatory markers, we have autoimmune markers in the domain of connective tissue disorders, and of course, imaging in the form of X-ray, USG, CT scans, echocardiography, etc., might contribute. The next slide. Before we move on to this slide, I would just like to point one issue. In this era of immunodiagnosis, we have a lot of immunological diagnosis coming our way. We should remember that immunological positivity always does not mean a confirmed diagnosis. And when we talk of investigations in the domain of PUO, it is important to remember the diagnostic test which is most likely to establish the diagnosis should be performed early rather than awaiting the results of many tests which are unlikely to contribute to the diagnosis. So this is where clinical prioritization comes in. And as I said, a procedure, a sequence, or a protocol should be followed when we talk of diagnosing a case of PUO. The next slide. Patients with symptoms and patients with fever will not have such clear-cut pictures as this. The next slide. So we can actually have patients whose investigations might be this way or that way. And this is one pattern which we see very often, which can be an interstitial lung disease, it can be an occupational lung disease, it can be viral pneumonia, it can be ALI, and there can be so many other entities, but all of these might present as PUO with or without respiratory symptoms. So the differential is important, and once we have the differential in the proper order of sequence, order pertinent investigations or pertinent tests. The next slide. This was one of our publications on etiology of study of fever of unknown origin. And out here, very interestingly, while we expect expected that there will be an infective cause as the commonest cause of FUO, is possibly in the form of tuberculosis or extrapulmonary tuberculosis. We were astounded to find that connective tissue disorders were the most common group of diagnosis which came up as a cause of FUO in our study. The next slide. This is the X-ray, which I think the postgraduates will jump into, and possibly the diagnosis of ALI is pretty evident if the X-ray is originating from the ICU. But then we should also remember the list which we presented as the possible causes of PUO, and this can well be a fungal pneumonia or a ventilator-associated pneumonia, which might be the cause of this fever and possibly breathlessness. The next slide. Coming to fungal pneumonia, we should have a clinical orientation or a clinical aptitude to the possibility of pulmonary histoplasmosis, which can present with very, very non-specific symptoms of fever, fatigue, and weight loss. There might be minimal or no respiratory symptomatology. There can be disseminated disease in the form of hepatosplenomegaly and weight loss, but the isolated pulmonary diseases are more common. And as you can see, extrapulmonary manifestation ranges from CNS to GI to skin. The next slide. And this is a very important cause of PUO in our setting today. We can have a presentation like MODS or sepsis, and you can actually have leukopenia, you can have elevated liver enzymes, you can have altered mentation and multi-organ dysfunction parameters in the form of coagulopathy, nephropathy, and hepatopathy. The next slide. This was a very, very classical example of PUO in one of our patients who was immunocompetent, non-diabetic, non-HIV, and the patient had persistent fever, and initially there was no pancytopenia, a moderate degree of pallor. So we were really at our wits' end as regarding a diagnosis, and ultimately at some point of time he developed bicytopenia in the form of leukopenia, and that was the time when we did a bone marrow, and lo and behold, we had yeast cells on bone marrow histopathology examination, and this was diagnosed to be a case of bone marrow histoplasmosis, which presented as PUO. We had a publication again with pancytopenia with HLH or hemophagocytic syndrome associated with histoplasmosis in HIV, and both these cases presented as PUO. The next slide. This is an X-ray from a very recent patient that I came across, where findings were actually very obscure, but the X-ray gave us a very, very easy clue to the possibility of fever being of respiratory origin. Why I'm showing this X-ray is to tell my colleagues or to remind my colleagues might be a clinical difficult situation to find the etiology of the disease. So you can have cavitations on lung X-ray, which might be evident, which might not be evident on a X-ray. You might need a CT scan to detect nodules and cavities in the lung. But then, what is the etiology of this pathology manifesting as PUO often remains obscure, often remains difficult. The next slide. So if you have this on the CT scan, you are well competent to make a provisional diagnosis of either a lung SOL or possibly a fungal ball in the setting of PUO. The next slide. However, multiple cavities can present without very, very distinct auscultatory or clinical findings. Even the X-ray might not be very discerning. And let us remember, there can be multiple etiologies which will present as prolonged fever in a patient with cavitary lung disease. One of this would, of course, be tuberculosis. The next slide. We can also have diseases like nocardiosis, which is important for the clinicians to remember. And nocardiosis can present without cavitary lung disease as well. There can be acid-fast organisms on sputum examination. You can have pulmonary aspergillosis without a fungal ball presentation. So you can have invasive pulmonary aspergillosis. You can have pulmonary cryptococcosis, which is a relatively difficult diagnosis. And above all, with cavitary lung disease, you can actually have venous granulomatosis presenting sometimes as hemoptysis, sometimes as nasal bleeding, but more often than not as PUO. The next slide, please. This was a very classical case of PUO that we encountered when we were in Kolkata Medical College. And there were multiple, you can see, liver abscesses, and we could make a histological diagnosis from aspiration of these lesions under USG guidance in those days. And this was one of my first encounters of hepatic tuberculosis. So this is really an uncommon presentation of tuberculosis. And believe me, extrapulmonary tuberculosis should be the dominant consideration in our country when we talk of PUO. The next slide. However, when you come across this sort of a picture, we should remember a clinical entity called hepatosplenic candidiasis. And hepatosplenic candidiasis, believe me, is a very fulminant illness. It can present with low-grade prolonged fever, but at the end of the day, it causes high leukocytosis, high fever. The patient can be really sick in the intensive care unit with multi-organ involvement. And when we talk of hepatosplenic candidiasis, for the benefit of the PG students who added this slide, please remember that not all Candida is Candida albicans. And why do we need to remember this? Because in today's setting, when you have prolonged fevers, you will have fungal infections as one of the important causes. And if you're treating Candida, you should remember that a large section of your non-albicans Candida will not be responsive to your azole antifungal agents. The next slide. So very often you need to include amphotericin B or the polyene antifungal agent into your prescription because non-albicans Candida will be refractory to your fluconazole or any azole for that matter. Prolonged fever with altered sensorium, again, TB comes top on the list, but let us remember that cryptococcal meningitis and CNS toxoplasmosis are also important entities. Apart from this, you can have a brain abscess, you can have rare disease like primary CNS lymphoma, which is EBV driven, and of course, you can have progressive multifocal leukoencephalopathy in the setting of immunodeficient conditions. The next slide. Cryptococcal meningitis. The India ink is insufficient. This is a very old slide. I think all of my audience and many of us have seen this slide before, but I keep on repeating this slide to remind ourselves that India ink preparation is inadequate and inappropriate, and you really need to go in for a cryptococcal antigen test for diagnosing cryptococcal meningitis. The next slide. One of the very common clinical associations of PUO is lymphadenopathy. And all lymphadenopathy is not this lymphadenopathy. So of the meticulous clinical examination that we were talking about, I think three things must be mentioned to this audience. Number one, look at the oral cavity properly. There might be telltale clues in the oral cavity. Look at the skin properly. We clinicians or we physicians often miss signs on the skin. It can be erythema nodosum, it can be an ulcer or a heel ulcer which the patient has chosen to ignore. And number three, look at lymphadenopathy or search for lymphadenopathy and hepatosplenomegaly. So these are three very important clinical connotations we must pay attention to when we are talking about pyrexia of unknown origin. The next slide. Because when we talk of lymphadenopathy, we must remember the relatively rare cause of lymphadenopathy. All lymphadenopathy is not lymphoma, it's neither TB lymph node, or it is not essentially a metastatic lymph node. You must remember the relatively rare cause of lymphadenopathy. This was our publication on Kikuchi's disease. You can have entities like Custom-Burns disease, relatively rare causes, infective causes like cat scratch disease and tularemia, etc. but then these must be somewhere down the ladder, because we are talking about lymphadenopathy and PUO, wherein by definition the basic investigations have failed or have failed to provide us a diagnosis. So the relatively obscure causes must be borne in mind. The next slide, please. Prolonged fever in HIV, I think there are human causes. So if it is HIV, I think the audience will be probably better equipped than me at this point of time to make a list of possibilities. But then this is another interesting case, which again emanates from my days at Medical College Kolkata, which shows splenic abscess. And believe me, ladies and gentlemen, splenic abscess is a very, very rare entity. So this was a splenic abscess, and again this proved to be extrapulmonary tuberculosis, a very rare form of tuberculosis, and the patient did well with standard ATD. The next slide. So this was the granulomas of tuberculosis on a splenic aspirate. The next slide. Fever with lower limb weakness. Now, this was a patient who had prolonged fever and was moving around, and people really did not have paid much attention to the neurological system. She came to us at a point of time which was pretty late down the course of the illness, and at that point of time, she had clinically significant lower limb weakness, and we diagnosed a case of epidural abscess and responded well to anti-tuberculous drugs. The next slide, please. Granulomatous hepatitis is a condition which is not restricted to the HIV setting. And remember, granulomatous hepatitis can be due to fungal infections. It can be due to tuberculosis, rarely. It can be due to sarcoidosis, or it can be due to non-specific granulomatous hepatitis. So granulomatous hepatitis is an important or prominent cause of PUO in today's setting. And we must remember that in this setting, the liver enzymes will be elevated, the LDH will be elevated, and we might do a liver biopsy, which will yield the diagnosis of granulomatous hepatitis. The next slide. The next. As I said, TB remains one of the most common causes of PUO in our setting, and you can have severe negative tuberculosis, atypical presentations, atypical locations, and all these can confound the clinician as causes of PUO. The next slide. Non-tuberculous mycobacteria. Now, non-tuberculous mycobacteria is relatively neglected entity, which is hardly ever discussed in our settings. But with more and more people living in elder age, more and more people living with oncology survivors, you have immunosuppressive drugs being used in rheumatology and cancer. You are bound to see more and more non-tuberculous mycobacteria or atypical mycobacteria. So atypical mycobacteria predominantly presents as PUO, but then there can be other issues like skin ulcers, there can be lymphadenopathy, there can be weight loss, and of course, in certain instances like avium intracellulare, there can be respiratory symptoms. So the possibility of non-tuberculous mycobacteria should be borne in mind when we are talking of pyrexia of unknown origin. The next slide. This was one of the patients whom we initially had acid-fast bacilli on examination of the discharge, and then we started on ATD. The patient initially responded, but then came back to us with a worsening of clinical situation, and ultimately a diagnosis of non-tuberculous mycobacteria was made. She had her 18 months course of treatment, and patient still remains one of my old grateful patients in Kolkata. The next slide. There can be extensive lymphadenopathy in atypical mycobacteria, which is important for us to remember. Hepatosplenomegaly might not be that important, but pyrexia of unknown origin, or prolonged pyrexia and lymphadenopathy and weight loss are the hallmarks of atypical mycobacterial illness. The next slide. Mediastinal adenopathy, often it might not be so prominent, but then it is important to remember that you can have lymph nodes which are not accessible to clinical examination. So when you're sending for a patient for ultrasound, which are routinely tell students, please mention special attention to retroperitoneal lymph nodes. Similar is the case for hilar adenopathy or mediastinal adenopathy. Next slide. Similarly, retroperitoneal lymph nodes. The next slide. These are some of the rarer causes of prolonged fever, but if you have enlarged adrenal masses or clinical presentation of hypoadrenalism in the form of hypotension, patient having cachexia, patient having hyponatremia, patient having pallor, and sometimes even hyperpigmentation, you need to look at the adrenals with a little bit of caution and extra attention, and the adrenals might give you a clue regarding an etiology of PUO in the form of adrenal tuberculosis or lymphomatous deposits on the adrenal, or even we have seen cases of adrenal histoplasmosis. So when you have a prolonged fever, which is associated with a hypotension and cachexia, remember the adrenals can be a cause. The next slide. This patient was admitted at North Bengal Medical College the week before last, and I don't know whether I can show you on this MR angio, but then this lady had a prolonged fever, and my PG found out that basically the pulses were weak in the lower extremities, and later on MR angio, it came out to be a case of coarctation of the aorta, possibly as a consequence of a vasculitic episode. So vasculitis can be one of the rarer causes of PUO, and as we were talking about spondyloarthropathy in the previous session, let us remember all the connective tissue disorders and vasculitis, to be more specific, are the missed issues which we fail to elicit or fail to diagnose at the initial evaluation as causes of PUO. The next slide. The next. This gentleman came to us with prolonged fever and a saturation which was less. He has been investigated outside. He was twice found to be COVID-19 negative, and there was no imaging done before he has come to us. He did not have leukocytosis. The blood pictures were all normal. We did a CT scan, which is almost routine in this setting, as you can understand. And lo and behold, this was possibly a very frank case of ILD or interstitial lung disease. And then on questioning, as we do, we missed questioning before, history taking before, it came out to be that he has been an industrial worker, and North Bengal basically has a very strong industrial pollution belt, and this was possibly a case of ILD, which had minimal respiratory symptoms, but then patient was having fever or low-grade fever for a long period of time. The next slide. This patient is still admitted in my ward, and this is any takers for this diagnosis? Sorry, I think we don't have interactions in this. The next slide. A florid case of multiple splenic abscess, and this is so obvious a finding, but then the patient has been to several health facilities with the problem of prolonged fever, and we could not do aspiration this time. She has been doing well on antibiotics, and the fever has subsided. Possibly this is non-tubercular because the patient is clinically responded, and we are hoping for the best. We will do a repeat CT in a few days' time. It is yet to be 2 weeks, so we have decided to repeat the CT scan after 2 weeks. The next slide. This is old patient of mine, old case of mine. This is from Calcutta National Medical College, and this was a healthcare worker who had fever without much symptoms. Other symptoms were general systemic symptoms. So nobody actually cared for the myalgia or the occasional headache. At one point of time, the lady had rhinorrhea, and later we had this imaging done, and multiple brain abscesses came out, and she went to a center in South India where they did neurosurgery on the lady, and ultimately she came back to us with a diagnosis of histoplasma brain abscess in an immunocompetent lady. The next slide. We have already said that cancer is a cause of fever, so you can really have all your leukemias and lymphomas as cause of fever. We had a short series of plasmablastic lymphoma in our immunocompromised population, and all of them uniformly had prolonged fever. The next slide. Going back to history and going back to clinical medicine, for heaven's sake, remember that drugs might be a cause of undiagnosed fever. So drug history, which has a relatively new onset of drug intakes, last 7 to 10 days, unremitting pyrexia, multiple negative blood cultures, and patient is otherwise well apart from the fever, relative bradycardia for the degree of the pyrexia, inflammatory markers low, and if the fever abates on withdrawing of the drug, I think we are in a position to make a diagnosis of drugs as a drug fever. The next slide. We cannot afford to forget the usual causes. Thyrotoxicosis can present as fever. The next slide. And low back pain, we were talking of spondyloarthropathy, low back pain associated fever.
For pointing up.
I think this is the last slide. This was tuberculous arachnoiditis, which had a prolonged history of fever. Patient had low backache, really not much of neurological symptoms, not much of neurological signs, or not much of neurological deficit. And later it was found that tuberculous arachnoiditis was the cause of this prolonged fever. The next slide. Friends, I think I've tried to give you a clinical overview of some causes of pyrexia of unknown origin. I really don't know whether I've done justice to this very long topic, but I hope you enjoyed some of my clinical scenarios. Thank you.
Thank you, Dr. Bandyopadhya. Thank you, Dr.
Very lucid and illuminating presentations, and particularly the illustrations with imaging as well as stomatology. Really very excellent lecture. But,
Thank you, Dipanjan, for a very excellent presentation and the beautiful exposition of the case files. There is one question in the chat box. Let me read it out for you. This is from Professor Arup Kumar Kundu. The question is immunodeficiency be included in the recent criteria of PUO? Your take on it.
Thank you, Arupda. Immunodeficiency is not a criteria of PUO. In fact, the diagnosis of immunodeficiency makes the spectrum more easier to diagnose. So PUO is a much broader spectrum for immunodeficiency. Maybe you have more clinical experiences with PUO in the domain of immunodeficiency, but immunodeficiency is not a clinical criteria.
There is one more question in the chat box. Can we make an empirical or trial with steroids in such a case when you don't find any cause for PUO as such? Empirical trial of steroids.
I think this is a important question, but relatively easy to answer. The answer is an emphatic no, because if we are using steroids to treat fever, we are actually obscuring the etiology of the fevers. There might be very, very restricted areas where you can use steroids as a life-saving medication, not to treat fever per se.
Do you advocate CT scanning of abdomen and thorax as a routine part of workup in PUO?
Let us understand that if the patient is qualifying as PUO, it means that the baseline investigations have all been done. So when the baseline investigations have been done, I think there are two things I would like to point out. Number one, go back to the history, go back to the clinical examination. We possibly might be missing something. In case that also doesn't reveal anything, then there is no harm if you do a CT thorax or a CT abdomen or maybe both. But rampant investigations makes the PUO more prolonged. That is what the literature is telling us.